A very big hello to all my dear students. How are you all? Welcome to your favorite channel, You and I with Dr. Ruchi Rai. So we are going to continue with the FMG rapid fire discussion. Okay? Which is the next slide? Any guesses? So this is one of the most important ones. We have to be very thorough with the anatomy. What are the things they can ask you? You all know these are the two cavernous sinuses, isn't it? And what are the nerves which are passing through the wall of the sinus is 3, 4 and 5. And we have to remember that 6th is passing through body of the sinus along with internal carotid artery. Correct? And this is the reason, if this is an important exam question, what is the first sign of cavernous sinus thrombosis? First sign of cavernous sinus thrombosis is 6th nerve palsy, right? So we will answer 6th nerve palsy. Okay. Okay. So once we know this, any other question? Yes, we should remember about pituitary gland, and any pituitary adenoma here can affect the optic chiasma, and because it affects the optic chiasma here, therefore it can lead to chiasmal lesions, that is bitemporal hemianopia. This is another point that you will keep in mind, right? So bitemporal hemianopia. Okay, so once we know this much, we come to the next slide. So let us take one by one. First, looking at this, what do you see? We see that the belly of the muscle is involved and the tendons are spared. Yes, we are talking about thyroid eye disease, and this is the myopathy in thyroid eye disease, right? So can you see this is the main belly which is involved. So it's a thyroid myopathy. Okay, what are the questions? Which is the first muscle to be involved? What will you answer? First muscle is inferior rectus. And if they ask you last muscle, then it is obliques. Mainly if they have to, you have to pinpoint, you can say last muscle is your inferior oblique, but mainly it is the obliques which are involved last. That is what is mentioned, right? And of course, it is a restrictive myopathy and forced duction test is positive, okay? Which is the first restrictive movement which is detected? Don't answer depression, it is defective elevation, because inferior rectus is fibrosed, even elevation is defective. So remember these questions. What are you looking here now? If you look at the CT, what you see in the optic nerve is fusiform enlargement of the optic nerve. So please revise this. We are talking about optic nerve glioma. Okay, so the CT scan shows fusiform enlargement. We all know optic nerve glioma is common in female children, right? And it is associated with, another question, NF1 patients, right? And most common, I will just pick up the questions. Most common pathological type is pilocytic astrocytoma. Pilocytic astrocytoma. We come to the next important slide here. If you see, this is your tubular vision, and this is the tubular, enlargement, and this is the tubular enlargement is seen in meningiomas. And we can even see that there is a calcification here. Okay, so this tubular enlargement is a feature of meningiomas, which are more common in middle-aged females. Middle-aged females instead of female children. That is one difference from optic nerve glioma. Second difference, of course, optic nerve glioma is from the astrocytes, glial cells, whereas this is from meningoepithelial cells. Third important thing, this one is associated with NF1, NF2, sorry. That was NF1, this is NF2. Another important point in pathology, we will not forget Samoma body. Okay, so these are some important points we will remember about optic nerve meningiomas, right? So please revise it. Yes, what are these? These are the most common ocular feature of NF1. What is this? We are looking at leash nodules, right? Which are hyperchromic nodules. This is most common ocular feature of NF1. We have already discussed, this is cherry red spot, right? And the second slide is we are showing is mucormycosis. So what are we looking at? What are we talking about? COVID-19. So in any COVID infection, most common ocular manifestation is conjunctivitis, follicular conjunctivitis, but COVID can lead to serious involvements like central retinal artery occlusion. And due to this, whenever we are giving steroids to the patient becomes immunocompromised and he can land up in mucormycosis. We have to remember, most commonly caused by rhizopus. This is one important point, as in the very important. And second, which is the drug to treat, we will answer amphotericin B. The drug to treat amphotericin B. Okay? And I hope you are very clear. This black fungus, it's not the fungus which is black, but it is mainly the necrosis of the tissue, right? Because it is very angio-invasive. Okay? Okay, we come to the next slide. If you have to give one name here, you said, okay, all related to COVID-19. What is one name you will give to all these slides? Blunt trauma, isn't it? So we all know that we are talking about Vossius ring. We have dealt with Vossius ring is iris imprint on the anterior capsule of the lens. These are the 2 points. Second, what you are looking at, this is your disinsertion of iris, iridodialysis, another feature of blunt trauma, iridodialysis. And exam question, what is the shape of pupil? It's a D-shaped pupil. It's a D-shaped pupil, right? Important. Then another feature of blunt trauma, hyphema. What are the 2 main disadvantages or dangers of hyphema? It can lead to glaucoma by impairing the drainage, and it can cause corneal staining, which is very tricky. You cannot manage it. You have to replace the cornea, right? So you can only prevent it by quickly removing the blood from the anterior chamber. And what is this? Very important, double Q. This is the teardrop sign of blowout fractures. Any blunt trauma can lead to fracture floor of orbit, and this is the soft tissue and edema which looks like teardrop sign. Okay? So blowout fractures are what? They are floor fractures. The name of the floor fracture, please don't get confused. Which is the weakest wall of the orbit if they ask you? Then you will answer it is medial wall is the weakest wall. Don't say inferior wall, okay? Why medial wall? Because of the cribriform plate of ethmoid sinus. The weakest wall is the medial wall, okay, for the orbit. If I ask you which is the weakest part of the floor where blowout fracture is happening, it is posteromedial part. Posteromedial part of floor. Okay? So these are important questions. We come to the next slide. What are you looking at? What I see is a, can anyone name this? This is festoon shaped pupil. Festoon due to multiple posterior synechiae. Festoon shaped pupil is seen in anterior uveitis. And of course, they have asked you these questions in Fmge exam. So any nodule at the pupillary border is Cope's nodule. Okay, it can be seen both in granulomatous and non-granulomatous inflammation. And what is this? At the base of the iris, this is what is Basaka nodule, right? That was Cope's, this is Basaka. Okay? So at the base of the iris, this is your Basaka nodule. Basaka nodule is mainly a feature of granulomatous inflammations. Right? Next slide. What are you looking at? This is connecting the sac to the nose. We are talking about dacryocystorhinostomy. Where do you make the opening? NLD opens where? Inferior meatus. So this is one question that NLD opens in inferior meatus. Where inferior meatus? Anteriorly. Isn't it? Then in DCR we make the opening where? Another question we will answer middle meatus. Okay, it is middle meatus. Next question, this has been asked as in given the image. This is nothing but bone punch to cut the nasal bone during DCR surgery. So this is your bone punch. Right? Next slide. Okay, so any inflammation which is at the margin, this is the acute infection or inflammation of the hair follicle, gland of disease, gland of, I'm not writing, revising with you. This is your hordeolum externum, which is called style. Okay, which is called style. So when you say externum, hordeolum का मतलब पता है? Hordeolum is swelling. So hordeolum externum means it is in the outer lid margin. Right? Okay, and of course another important. So it's a staphylococcal infection of hair follicle, gland of disease, gland of moth. This is what they've asked. Coming to acute inflammation of meibomian gland, this becomes hordeolum internum. Right? It is acute inflammation of meibomian gland. Okay, and what is This is for, these are the instruments for what? Chronic granulomatous inflammation of meibomian gland को क्या बुलाते हो? Chronic granulomatous inflammation of meibomian gland means, you just remember this, that you had that it is mainly the almost like this, but this is not acutely inflamed, it is mainly painless. Then it is hordeolum. Then it is not hordeolum internum if this is not acute inflammation. If it is a chronic inflammation, we call it what? Yes, calagion, isn't it? We all know calagion. So you should remember this is calagion. What is this? They can ask you, they have asked you in the exam, this is calagion clamp and this is the calagion scoop. Right? Any repeated calagion, recurrent calagion should be suspected for, you will say sebaceous cell carcinoma. Right? Yeah. But most common cause of recurrent calagion, uncorrected mild refractive error. Keep in mind, it is uncorrected mild refractive error. So this is it. This is a calagion. I hope you're clear now. Painless swelling, chronic granulomatous of meibomian gland, inflammation of meibomian gland. Okay, next slide. We look here. We can see the double row of eyelashes out here, right? So one row is here also, and here this is what is called dystichiasis. Double row of eyelashes को क्या बुलाते हैं? You will say this is called dystichiasis. And thickening of the lid margin, this is what is stylosis. And graying of eyelashes, this is what is poliosis. So you should know all this, right? And of course, inability to close the eye. What do you call this? Inability to close the eye fully is legophthalmos. Why will it happen? Which muscle closes your eye? It is orbicularis oculi. So which is supplied by seventh nerve. So this can happen in seventh nerve palsy. How can it complicate? It can complicate into, tell me, it can lead to exposure keratopathy, right? And this is what is called neurotrophic, correcting myself, it is neuroparalytic keratitis. Yani ki when there is a seventh nerve palsy leading to legophthalmos, leading to exposure keratopathy, this is what is neuroparalytic keratitis. Anyway, what is neurotrophic? That is when it is fifth nerve involvement, then we call it neurotrophic. Come to the next slide. Yes, I think you know what we're talking about. So there is a telecanthus. C says that this distance is more. There is shortening, okay, blepharophimosis, shortening of the horizontal length. There is a phimosis. And of course, if you look at these are the white arrows, which I'll now put it as green like this. This is epicanthus inversus, extra fold of skin, which is arising from the lower lid. And what does this show? This shows ptosis. Okay, so revise it. This is your blepharophimosis syndrome. Right? Kya kya tha? And one more apart from telecanthus, blepharophimosis, that is horizontal length is small, ptosis and epicanthus inversus. एक और क्या है? Congenital ectropion of lower lid. So all these are features of blepharophimosis syndrome. And what is this? I think you all can tell me this one. You see in this figure, the child has ptosis here, isn't it? And this eye position of the lid is normal. In right eye, there's ptosis. When he moves his jaw, what happens is this ptosis gets corrected, right? What are you looking at? There's an abnormal connection between the LPS, which is supplied by third nerve, and lateral pterygoid, which is supplied by fifth nerve. Now tell me, what are you talking about? Yes, this is Marcus-Gunn jaw winking phenomenon. Okay, so this is what is Marcus-Gunn jaw winking phenomenon. Okay, we come to the next slide here. What is this? Yes, they can ask you, what is this? This is your Snellen's acuity chart. Everybody is clear with the basics here? When you say 6 by 9, 6 by 12, what is normal? Denominator is normal. When I say 6 by 12, it means that a normal person can read this letter at 12 meters, which my patient is only reading at 6 meters. Okay, similarly 6 by 18, 36, 60 and so on, right? So this is your Snellen's acuity chart, and what is the basic that you have to know? Every letter in the chart subtends an angle of, if you are looking at a letter E, suppose, which is the whole letter will subtend an angle of 5 minutes. Okay, and the margin of the letter subtends an angle of 1 minute. Just write in my way. Where is this angle? At the nodal point of the patient's eye. Okay, and when you say this, then you have to think yourself, how can the smallest letter and the largest letter subtend the same angle? What is different is the distance. So the largest letter will subtend this at 60-meter distance, but the smallest letter subtends at 6-meter distance. I hope you are clear. So Snellen's equity chart basic should be absolutely clear, right? Okay. And with every marginal letter 1 minute, so how you make every letter? You make a box and it has 5 small squares, as you can see here, 1, 2, 3, 4, 5 everywhere. That is why margin 1 minute and overall letter is always into 5. This is how you actually draw and make the Snell. And this is of course the Landauer's C-ring. This is again based on the same concept. We next talk about what is this. Of course, we all know we are talking about pinhole test or pinhole. First question, pinhole, what is the size? It is either 1 millimeter or it can be 1.25 millimeter. What is a pinhole test? Common sense. Pinhole test में क्या है? After doing the refraction, when you put the pinhole to the patient, if his vision improves, इसका मतलब there is some remaining refractive error which has to be corrected. But suppose there is any central opacity or any lesion in the macula, then vision will deteriorate, decreases. Then, as I said, note down, it can be a macular lesion or central opacity. What are you looking at? Yes, this is the patching in this child. And yes, what we are talking about, important topic for you all, amblyopia, do revise it. So when you say amblyopia, it's a partial loss of vision with no organic cause. Can you tell me in this patient, in this cute child, which eye is amblyopic? Which eye is amblyopic? Of course, it is this right eye which is amblyopic. We always patch the normal eye, right? Because we want to stimulate the amblyopic eye, we want to stimulate its fovea. Okay? So please remember, the treatment of choice of amblyopia is occlusion of the normal eye. Okay? Yeah. So please revise this topic. And of course, you should be very, very clear what is myopia is when the focusing is in front of the retina. Why it is so? I hope you have thought about. The power in the eye is more than I require. Too much of bending of light rays, so it focuses in front. When power is less than what I required, it takes a long time to focus. This is hyperopia behind the retina. Okay. So if it is a myopia, too much of power, just remember like this M for M, myopia is more power. I want to decrease the power, I use a concave lens, right? And if I have too much less power and I have to increase, then I use convex lens. So myopia is more power, you have to decrease it, you use concave lens. Hypermetropia means less power, you have to increase the power, you use convex. So there in a myopia concave and here convex. Correct? Hope it's clear. Okay. So this basics should be clear. And then what is astigmatism? When there are more than one focal points, right? And it should be very, very clear to you all if this is the cornea, is one axis is more steeper than another. So naturally the focal points are different on the retina. This is astigmatism. The patient will see blurred. You know? Okay. Once you know this, you should also know what is simple myopic. Simple myopic means one axis has no number, other is a myopia. Yani one axis, the focusing is good. In other axis, it is in front. If one axis focusing is good, other axis it is behind. This is simple hypermetropic, isn't it? I can show it like this, simple hypermetropic. Okay. And how do you show compound myopic? I will show it as both are minus. What is compound hypermetropic means? Both are plus, means both are behind the retina. And one plus and one minus is mixed astigmatism. So this is one way of classifying astigmatism. Is there any other way of classifying? Just remember one more, what is with the rule and against the rule. When you say with the rule, vertical is more than horizontal. When vertical power is more than horizontal, this is with the rule. And if it is vice versa, horizontal is more, so sorry. Just 1 minute. It is the horizontal which is more than vertical. Now this one is more. This is called against the rule astigmatism. Please revise this, right? So, okay, very, very quick question here for you all. If I say this is 0 and this is plus 1. So, where is power more? Sometimes you all get confused. So, please, 0 means emetropic eye ka power kitna hota hai? 60 diopters. +1 is hypermetropia. Plus and minus on a retinoscopy means plus is hypermetropia and minus is myopia. So when you say +1, it means 60 minus 1. Actually, it is a 59. So this is lesser, this is more. So this is against the rule. So don't forget 0 is 60. Anything in minus means you have to add in 60. For example, if I say, tell me -3 minus 2, what type of astigmatism? -3 matlab 60 plus 3, 63. Minus 2 means 62. So this is with the rule astigmatism. Got it? So this is the way we have to solve these questions. Okay. What is this? Of course, you should be able to recognize. This is your stenopic slit. You have learned about Fmge's test. Right? Stenopic slit can also be used to assess where should I go for an optical iridectomy. If the pupil is not working, I want to create another artificial pupil. That is called optical iridectomy. So how to do that? That this will help you when you rotate the stenopic slit and see where the patient is able to see the best. Okay? Okay, so you should be able to recognize, and yes, what is the size? You should know it is 1 millimeter and length is 15 millimeters. Okay, next slide. This is done. This is not ophthalmoscope. This is a streak retinoscope. Please learn to recognize it. Okay, retinoscopy इससे करते हैं. This is streak retinoscope. And of course, you have to know about your yoke muscles. Very simple. Listen to me. When you are looking to the right, then your right lateral, left medial. When you are looking to the left, left lateral rectus and right. This is clear? Okay, let me go one step more further, one step more back. So you all know there are 6 muscles, 4 recti, 2 obliques. यहाँ तक तो clear है? Please revise your action of muscles. Now, how we will learn? What are yoke muscles? They are contralateral synergists. What do you mean by contralateral synergists? Means 2 muscles of different ties are working together. So horizontal is clear, right lateral, left medial, left lateral, right medial. You all get confused with dextro. Dextro is right, levo is left. Dextro elevation, dextro depression. Levo elevation, levo depression. Very simple. Just note down this rule. Please write down. I'm not writing. In an outward deviated eye, action of elevation and depression is always of recti. So once you look here, what are the muscles which elevate? Think like this. Superior rectus, inferior oblique. Which is the outward eye? It is the right. So it is right superior rectus, left inferior oblique. So if it is a dextro elevation, this is a right gaze. This becomes your dextro elevation. And in dextro elevation, it is right superior rectus and left inferior oblique. When you say, suppose levo depression pe aa jao. So levo depression is this. So what are the muscles? First question, what are the muscles which depress? It is inferior rectus, superior oblique. Which is the outward deviated? It is your left eye. So left का क्या काम करेगा? Recti. So it is the left inferior rectus, right superior oblique. So when you go into the left gaze, levo depression, left inferior rectus, right superior oblique. Okay. So just remember this rule. You will be able to solve it. It's very simple. अच्छा, ये बताओ, you all know what is Herring's law? है ना? Equal innervation in yoke muscles. Don't forget that. And Herring's law, Sherrington's law says equal but reciprocal innervation in agonist and antagonist. Just revise this. What are you now looking at? If you'll see, the position of the eye is down and out, isn't it? Down and out position with ptosis. Okay? No adduction, but abduction is fine. We are talking about third nerve path. Okay, so this is your third nerve path. Next slide. Now this child, very important, has an esotropia here. Can you see that? But when she is wearing specs, the eyes become straight. Why it is happening? It's because she has refractive accommodative squint. So I want you all to revise your accommodative squint. They have asked you which refractive error? Accommodative squints, it is due to hypermetropia. Okay, I'll explain you very quickly. If this child has any hypermetropia, which is a little higher hypermetropia, and she is not using specs, so what is happening? Hypermetropia kya hai? Less power in eye. How can the eye increase your power by itself? By accommodation. So this child's eye will exert a lot of accommodation. And what is the part of near reflex? Accommodation, convergence, meiosis. Too much of accommodation, say there is convergence of the eyes. That is why when you correct this hypermetropia, now the eye will not exert so much of accommodation. Then what will happen? Convergence will relax and the eyes will become straight. So this is what is refractive accommodative esotropia. These are actually correcting the hypermetropia. right? And also revise what is non-refractive, where the AC by A ratio is more. Just this topic you have to learn nicely, right? Okay. Coming to the next slide, you see this psi, I can see a hypertropia, right? This hypertropia, when you are bending on the same side tilt, okay, and it is increasing, but opposite side tilt, it is not, it is becoming normal, it becomes straight and normal. So this is what Bilchowski's sign of superior oblique palsy. So superior oblique palsy, a tip I will give you here very quickly, will increase on the hypertropia increases. Okay, the hypertropia increases on same side tilt and opposite gaze. Okay, just remember, if your action of muscles are good, if you're thorough with that, you will be able to understand. Superior oblique primary action in torsion. What else it does? It is superior, but it is oblique, so it depresses, and abduction, right? So that is what is lost. So that is why the eye is hypertropic. Okay. Yes, we come to this one. I hope you all know this. This has been asked so many times. This is Ishihara chart. Ishihara chart is mainly used for screening of color blindness. It mainly catches red and green blindness. In OPD procedure, very common. When you talk about this one, this is most sensitive test. Just remember this, which can catch hold of all types of color blindness, and it is called Farnsworth-Munsell 100 hue test. Farnsworth-Munsell 100 hue test. Okay? Okay, but these are only not 100 hues, actually there are only 85 caps. Okay. And what is this? Of course, you all know this is a repeated question. This is the WHO program under this to control trachoma, isn't it? What is, so recently this has been reported that trachoma has been eradicated from India, right? So when you talk about trachoma, S stands for surgery. Which surgery? So we are treating here trichiasis surgery or entropy, दोनों correct हैं, okay? So then A for safe strategy में A for antibiotics. Which antibiotics? Oral azithromycin या topical tetracycline ointment. How much percent? 1%. Okay, facial hygiene and environmental cleanliness. Okay, so remember all these points. So let's note down azithromycin की dose पता है ना? In adults, it is 1 gram. In children, it is 20 milligrams per kg. This is, of course, the choice because tetracycline is one, it is less effective. Second, compliance is a big issue. Okay. Okay. Putting ointment can be really difficult and the patient may not be compliant. Right, all of you? So that was it. I hope it will help you. This is my little effort to help you all for a rapid revision and let you know that these are the topics which you cannot avoid before your exams. Be thorough with that. Concept should be clear, then everything will be fine, right? So work harder, run faster each day because this is the last lap towards your exam. Okay, again I'm saying no complaints, no self-pity. I will be better than yesterday. I'm going to, even if I'm studying 15 minutes more, it should be a productive study, right? Be sincere towards yourself. So thank you so much. Stay blessed. All the best. Keep smiling.